Hi, everybody. I get to introduce our lovely Violet Swanson. She is finishing her residency here after doing med school at Liberty University. And she got her bachelor's in science in human nutrition, foods, and exercise from Virginia Tech. She is passionate about promoting health and wellness to support growth and development of children. And we are very excited that she is staying on as our fourth-year chief resident. And as a note, please make sure you are emailing or texting the right Violet when you have chief questions. So please join me in welcoming Dr. Violet Swanson to Pediatric Rounds.
It's only right for you to introduce me. All right, good morning, everybody. Today I will be talking about pediatric obesity and GLP-1 agonists. I have no financial disclosures. Here are our main objectives today. So going through the mainstay of pediatric obesity medicine and current pharmacotherapy, as well as reviewing the GLP-1 agonists, their mechanism of action, efficacy and safety, as well as clinical considerations for initiating them, and then difficulties in obtaining and covering medication. So pediatric obesity is continuing to rise. It is now 1 out of every 5 children is obese, so 20% of the US population. And this is more so in marginalized populations, specifically Hispanic and non-Hispanic Black children, as well as American Indian and Alaskan Natives tend to have higher rates of obesity. This is important because this increases their risk for other comorbid conditions, including type 2 diabetes, metabolic associated steatotic liver disease, obstructive sleep apnea, hypertension, and dyslipidemia. So obese adolescents have approximately 80% likelihood of remaining obese into adulthood. That's why I wanted to talk about this a little more today. In contrast, adolescents who are able to lose weight before adulthood are actually more likely to maintain a healthy weight and have similar cardiometabolic profiles to those that were never obese to begin with. So there are so many things that interplay into obesity, from policy factors, including the marketing of unhealthy foods, under-resourced communities, to community factors, including schools, lack of access to fresh food, lack of access to a safe space for physical activity, and the proximity to fast food, and family factors, including family dynamics and attitudes towards food, eating out, portion sizes, excessive screen time, sedentary behavior, short sleep duration, and adverse childhood experiences. Cumulative adverse childhood experiences actually double the risk of children being overweight or obese compared to those who do not have adverse childhood experiences. Individual factors include genetics, most often polygenetic or epigenetic factors. However, there are a few monogenetic causes of obesity. Prenatal risk include parental obesity, gestational diabetes. Some postnatal risk factors include birth weight, so either low birth weight, less than 2,500 grams, or high birth weight, greater than 4,000 grams, are at increased risk for later obesity, as well as rapid weight gain in infancy and early childhood. Childhood risk include children that have autism spectrum disorder, children with other intellectual or physical disabilities, endocrine disorders. However, this of course only accounts for less than 1% of the causes of pediatric obesity. Medications, including common implicators such as glucocorticoids, insulin, antipsychotics, anti-epileptic medications, and depression as well plays a role. So traditional management to obesity, first and foremost, it is important to assess the child and the family's readiness to change. This gives you insight and guidance on how to work with the family based off of their personal motivations, goals, and barriers. You want to evaluate for comorbidities. The specifics of this are beyond the scope of this presentation, but this includes screening labs such as fasting lipids, A1C, ALT, as well as reviewing blood pressures for risk of hypertension, as well as evaluating for other possible symptoms for other common comorbidities such as obstructive sleep apnea, PCOS, and idiopathic intracranial hypertension. So intensive health, behavior, and lifestyle treatment is the standard of care for the treatment of pediatric obesity. This is child-focused and family-centered and includes 26 plus contact hours in a 12-month period. There is like a schema that the AAP presents, as you see here, with clinic visits, one time a month, group sessions, telephone check-ins, health messaging, just multiple means of trying to keep this at the forefront of attention. So nutrition therapy is important to address to help them learn to make informed choices and decisions about food. Physical activity, it's important for them to build muscle, endurance, and confidence, and it affects body fat percentage, which influences their comorbidities. And behavioral modifications as well is also important to address because there are often associated psychological and emotional needs. So the effectiveness of intensive health, behavior, and lifestyle treatment alone produces small but statistically significant reductions in BMI and BMI-Z scores compared to no treatment. Pooled analyses demonstrate about a mean difference in BMI of approximately 0.4 to 0.9 kilograms per meter squared reduced, so less than 1 point of BMI, or a Z-score reduction of minus 0.06 to minus 0.13, with greatest effects observed in those who had interventions of higher intensity, longer duration, and the group that it was most being effective in was children aged 6 to 12 years of age. So with that, sometimes intensive health, behavior, and lifestyle treatment alone may yield only modest or short-lived results for those, especially with higher obesity. So medical interventions are an adjunctive tool in your toolbox to use for children who may not or may need more than just intensive health, behavior, and lifestyle treatment. In particular, those with more immediate and life-threatening comorbidities, those that are older, and those affected by more severe obesity. Medications are an option, but for children less than 12 years old, there is currently insufficient evidence to support use of pharmacotherapy. And then we'll get into more about medicines in a little bit, but bariatric surgery is also an option. This is an option for those that are physiologically mature enough so they're completing puberty, and they're either in the 120th percentile with clinically significant comorbidities, or they are greater than the 140th percentile. It is important to note that while pharmacotherapy and surgery have greater efficacy, they also carry higher risks of adverse effects and require careful patient selection. There is risk of weight regain, more so with medications, but can also happen with surgery that can lead to surgical complications. And also medications and surgery don't change behavior, so that's a really important thing to keep in mind. Okay, medication options. So these are the common medications that have been used for pediatric obesity in the past. Metformin has been used in patients that are greater than 10 years old who have type 2 diabetes. It reduces glucose levels by decreasing blood glucose production in the liver, decreasing intestinal absorption, and increasing insulin sensitivity. The evidence for weight loss with metformin is conflicting. Studies typically include higher metformin doses, more intensive lifestyle modifications, and use in children and adolescents with more severe obesity and or a secondary diagnosis of diabetes or PCOS. Adverse effects of metformin include bloating, nausea, flatulence, and diarrhea. Orlistat is another medication option. It is an intestinal lipase inhibitor that blocks fat absorption. This is an FDA-approved medication for obesity in patients greater than or equal to 12 years of age. However, the adverse effects are often not very tolerable. It increases diarrhea, fecal urgency, and flatulence. Phentermine is a norepinephrine reuptake inhibitor and also non-selectively inhibits serotonin and dopamine reuptake and reduces appetite. It is approved for patients greater than or equal to 16 years of age for up to a 12-week duration, which is not long. Adverse effects include elevated heart rate, elevated blood pressure, dizziness, headache, tremor, dry mouth, and stomach ache. Topiramate is a carbonic anhydrase inhibitor, and it, through an unknown mechanism, suppresses appetite centrally. Some adverse effects include cognitive slowing. It's teratogenic. There are mood changes often associated, as well as visual changes with risk of glaucoma, as well as skin reactions including SJS and TEN. Only recently, in 2022, was the combination of phentermine and topiramate approved for patients greater than or equal to 12 years of age. It is approved for long-term use up to 2 years. The study that looked at phentermine topiramate combination saw about a 5 to 7% decrease of their BMI, which is more than each of these medications alone. The safety info, of course, includes both of the side effects from phentermine and topiramate. Also in the studies, they saw slowing of linear growth and reduced bone mineral density in pediatric patients, so that's also an important consideration. Hello. Don't know what that was. Okay. All right. So introducing the GLP-1s. So GLP-1 receptor agonists were originally developed for type 2 diabetes. And while they were being used in those with type 2 diabetes, there was a recognized effect on weight loss. This led to several studies being done and 2 FDA-approved medications for adolescents greater than or equal to 12 years of age with obesity. And this includes in 2020, liraglutide was approved, and 2022, semaglutide was approved. These work by mimicking endogenous GLP-1 secretion, which is an incretin hormone. Its mechanism of action modulates both all in the brain with increase in satiety and decrease in appetite. Pancreas with stimulating insulin secretion and suppressing glucagon secretion, and in the intestines with slowing gastric emptying. So looking at the evidence, first we'll review liraglutide. So there was the SCALE teen trial that was done for liraglutide. It was a randomized double-blind placebo-controlled trial. It included 56 weeks of treatment with dose escalation over 4 to 8 weeks, and a 26-week follow-up period after discontinuation of the medication. It included patients 12 to 18 years of age with obesity and poor response to lifestyle in a 1-to-1 placebo to intervention comparison. And the intervention was compared to placebo plus lifestyle changes, and both groups got lifestyle changes. So with liraglutide, there was a 4.29% decrease in BMI in the intervention group compared to 0.35% increase in the placebo group. There was greater than or equal to 5% weight loss in about 43% of the patients that were in the intervention group, and then 19% of the patients in the placebo group. GI side effects were more common in the intervention group, 64.8% versus 36.5%. GI side effects most commonly occurred during dose escalation, and then often would become less frequent and more tolerable. Other side effects of note, one patient in the liraglutide group committed suicide and there were 2 suicidal attempts, one from each group separately, but this was later determined to not be an effect of the medication. One participant in the placebo group had acute cholecystitis and cholelithiasis during treatment, and one participant in the liraglutide group had a single episode of pancreatitis that recovered without treatment. The trial also looked at cardiometabolic effects in these patients, and it showed no substantial differences between the liraglutide group and the placebo group in terms of lipids, blood pressure, dysglycemia, and waist circumference. There, as you can see in the graph, was greater weight regain and rebound in the BMI after drug discontinuation when followed for another 26 weeks. Semaglutide, this is the STEP Teens trial done in 2022. It, again, was randomized, double-blind, and placebo-controlled. Again, looked at 12 to 18-year-olds with obesity. This time it was a 2-to-1 ratio with intervention to placebo. And the study was done over a 68-week period of treatment with a 16-week dose escalation period. And they were followed for up to 75 weeks. So the effects on BMI were pretty significant. In the intervention group, a decrease of 16.1%, and in the placebo group, a very small increase in 0.6% with BMI. And then in the intervention group, 73% achieved greater than 5% weight loss, and 18% of placebo were able to achieve the same greater than 5% weight loss. GI side effects include 62% in the intervention versus 42% in placebo, which again shows that increase in GI side effects with this medication. Again, with this medication as well, the most common time that these side effects would occur would be shortly after escalation of the dose. Again, with side effects, 5 participants in this trial in the intervention group did develop cholelithiasis, and one of those patients also had cholecystitis. So that was about 4% of the intervention group and 0% of the placebo group. The amylase and lipase were also tracked, as it has been known to increase risk of pancreatitis. However, there were no cases of pancreatitis, so there was an increase in amylase and lipase in the intervention group compared to the placebo group. There is a significant reduction in cardiometabolic markers, including waist circumference, hemoglobin A1C, total cholesterol, LDL, VLDL, and triglycerides, as well as ALT levels. These were all significantly lower than the placebo group. So, practical implications. The AAP's clinical practice guideline released in 2023 recommends considering pharmacotherapy for children with a BMI greater than or equal to the 95th percentile, which is obesity, with significant comorbidities, or a BMI greater than or equal to the 120th percentile in the absence of comorbidities. Patients need to be greater than or equal to the age of 12 years old. It is administered subcutaneously, and common side effects that we have already talked about include nausea, vomiting, diarrhea, constipation, and abdominal pain, as well as rare complications including pancreatitis and cholelithiasis. Pediatric patients compared to adult patients in those trials. So for semaglutide, pediatric patients had a greater incidence of cholelithiasis, cholecystitis, hypertension, rash, and urticaria compared to adults treated with semaglutide. And then with liraglutide, it is to be noted that there is a little bit of an increased risk of hypoglycemia compared to the placebo group as well as compared to adults. And then contraindications to use of this medication include personal or family history of medullary thyroid carcinoma. In rodent studies, GLP-1 receptor agonists caused dose-dependent and treatment duration-dependent thyroid C-cell tumors. And it hasn't necessarily been demonstrated in human populations, but we've also been avoiding them in humans. So contraindicated for those populations as well as those with MEN2, who are also at increased risk for medullary thyroid carcinoma. And there's currently not enough evidence done in those with pregnancy to encourage this medication use. So practical application of how do we use this medication. So these are the three medications that have the greatest effect on weight loss that are FDA approved for pediatric patients. So semaglutide, liraglutide, and the venturamine topiramate. So with the semaglutide, titration occurs every 4 weeks. It is a weekly administered medication, and the maintenance dose that you're aiming for is 1.7 to 2.4 milligrams. This often is about like a 16-week titration. The liraglutide is a daily injection. It's titrated up every week up to a maintenance dose of 2.4 to 3.0 milligrams daily. And it may take up to 8 weeks to get to a therapeutic dose. The venturamine topiramate is titrated up every 2 weeks, and ideally with a maintenance dose of 7.5 milligrams of venturamine with 46 milligrams of topiramate. However, if weight loss is less than 3% with this dose, after 12 weeks, then you can either discontinue the medication or increase the dose up to 15 milligrams of venturamine and 92 milligrams of topiramate. And this again is increased in a every 2 week fashion. Once you're on a higher dose of the venturamine topiramate, it's important to do a gradual discontinuation of the medication because if you just abruptly discontinue that, then it does have an increased risk of precipitating seizures. As general practitioners, it would be important to, with these medications, monitor weight, side effects, and comorbid conditions for all of these treatments. It would be recommended to follow up monthly while escalating medications and maybe even bi-weekly while escalating liraglutide or venturamine topiramate. And then once in maintenance, depending on where they also get their intensive health and behavior lifestyle treatment, either following up monthly to continue to encourage and participate in that treatment, or every 3 months if they're getting that from other sources as well.
Dr. Swanson, do you know, are they like a one injection? Is it just a pen that because they're not doing any mixing or anything, right?
It just a pen.
So it gives them the dose escalation as well as like a pack.
It does. Yeah. And then
getting it from a compounding pharmacy.
Okay.
The venturamine topiramate is the oral medication compared to the GLP-1s that are subcutaneous, but yes. For venturamine topiramate, the additional considerations for this one would require some more laboratory testing, including negative pregnancy tests before starting treatment, as well as a BMP prior to starting treatment, specifically looking at bicarb, potassium, and creatinine. And then monthly pregnancy tests as well as BMPs while on the medication to make sure that they aren't pregnant, as well as continue to keep an eye on the bicarbonate, potassium, and creatinine. The serum bicarb tends to peak within 4 weeks of treatment and should correct on its own, while the serum creatinine peaks within the first 4 to 8 weeks, but then declines and remains slightly elevated above baseline values. And if these values are off, then treatment should be discontinued. So, rule of thumb, hopefully, yes, rule of thumb, but a bad thumb, is if weight loss is less than 5% after 12 weeks of maintenance therapy with these medications, then it's likely an inadequate response and you should probably discontinue treatment. Insurance tends to have this threshold as well if they're going to continue to approve the medication.
Is there any rates of how common that is?
How common it is to discontinue the medication with less than, well, with the trials, semaglutide had about less than 50% were able to achieve greater than 5%, and there are some insurances that take maybe 4% weight loss, but with semaglutide and phentermine topiramate, semaglutide had that higher, like 70% or more were able to obtain the greater than 5% weight loss. And then phentermine topiramate, I don't recall the exact percentage, but the average percentage that was lost was between like 4.7 to 7 or 8% weight loss. So. And
then sometimes when you see combo medicines, we'll also just give each medicine individually. Mm-hmm. Is that a practice at all, or is it only really being done as the combo medicine because of the way it doses them? Do you know?
I think that it has been done with giving both of those medications at the same time. I haven't personally done it, but I know that Dr. Powell is online, so maybe she can provide insight.
Looking at the listservs that I'm on, it seems that very few insurances will pay for the combination medication, which is about $100 a month. And so almost all of us are prescribing it separately because it's generic. Clearly, you can't get the dosing in the same exact ratios as the proprietary medication, but we sort of ballpark it at that point. I'm sure they did that on purpose too.
So we would have to use this combination medication? No. Yeah.
Thanks, Dr. Powell.
Thank you, Dr. Powell. All right. Additional considerations. So with nutrition, adequate portion sizes and mindful eating is important to prevent overeating and overfilling the stomach with the delayed gastric emptying to reduce the rate of symptoms. And decreased appetite is an effect of these medications. So promoting no meal skipping, as well as being mindful of restricted and disordered eating behaviors. And then with exercise, in some adult trials, elderly adults, they saw an increased risk of sarcopenia or muscle loss. And so more research needs to be had in kids, but in general, it's a good recommendation to encourage weight-bearing exercise to improve muscle mass. And behaviorally, there is still stigma about this being a shortcut to weight loss. There's stigma for being overweight or obese, but there's also stigma against taking medication to help improve yourself. Similar to mental health, some people are just able to go to counseling, but some people might need medications, and that is also still stigmatized. So this kind of falls into line with that. All right, challenges. So access and insurance challenges. There are still perceptions that GLP-1 receptor agonists are only adult therapy treatments, and insurance has this perception as well. And so when working with Dr. Powell, learning that Virginia Medicaid, the liraglutide is approved for those greater than 12 years of age or older, but the semaglutide is only approved for those 18 years or older. And they are new and expensive. They're about $1,400 per month. And there's on and off issues with shortages, and the supply has yet to meet the demand. Prior authorization is also a frustrating issue. They often need documentation that the BMI is greater than or equal to the 95th percentile, and at least 6 months of supervised lifestyle interventions that have failed. And then a detailed medical necessity statement. This includes looking at comorbidities, which often they see as heart attack or stroke, but they often don't care about things like prediabetes or maybe even metabolic associated liver disease. So other common denials, denials are common and appeals are often needed, so it's important to advocate for those patients with persistence. And then if access remains restricted, this does increase the risk of widening health disparities with those in those that already have healthcare disparities are at increased risk for obesity. Yeah.
All right, so many questions. The supervised lifestyle interventions, are they very strict about that? You know, because I'm just thinking that's almost a barrier, right? Like, because so many families can't get into clinic once a month or multiple times a month. Is that well defined that you know of, or kind of what's that look like? Is it just, hey, we're trying to lose weight and we're following your weight?
I think it's variable. At the very least, and Dr. Powell, yes.
Okay. What we're finding in terms of filling out the forms is that you need to document that they're involved in some sort of nutritional counseling, and that they have an exercise plan, and it's some of it's just the wordage that you put in the letter for the prior auth. They all require prior auths. Most of them you have to appeal it at least once before they'll do it, and then every 6 months you have to redo it.
Thank you very much, Dr. Powell. Good question. Yeah, that is a difficulty with the ideal intensive health lifestyle behavioral treatment being greater than 26 plus hours of contact, and it can be really difficult for families, especially families that have difficulties with access to care. So there is a lot that we still don't know. There is an uncertain optimal duration for pharmacotherapy in adolescents. As you saw, with discontinuation of the medication, there can oftentimes be weight regain. So how long do they need to be on this medication for in order to see sustained effects, even after discontinuation? And how do these drugs impact growth, puberty, and neurodevelopment? Growth and puberty were monitored during both of the trials that were done, but also long-term effects, or if this is to become younger and younger in use, how will that affect growth and puberty? And then what is the long-term safety of these medications? Those trials were done over like a 2-year span. So how does that affect patients long-term? As well as, are there any individual factors that can help predict treatment response so that we don't have to go through a trial of medication and the medication failure? So there are more and more studies to be done. There are some active clinical trials right now, including the phase 4 trial of semaglutide that looks at weight maintenance. This is going to be use of the medication for a minimum of 3 years, but up to 6 years, and it will look at longer outcome data. There is also a study being done looking at cardiometabolic comorbidities, including prediabetes, new onset type 2 diabetes, and metabolic associated celiac liver disease, and how this medication can affect those comorbidities. Recently, actually, in adults, semaglutide received FDA approval to reduce the risk of cardiovascular death, stroke, and heart attack in overweight or obese adults. Tirzepatide is on the rise. It is a dual GLP-1 receptor agonist. GIP is another incretin hormone, and a phase 3 trial is underway. That's a 90-week trial in adolescents with obesity or overweight with comorbidities, and this medication has shown a higher weight loss efficacy in adults compared to semaglutide. There's also orforglipron, which is an oral GLP-1 receptor agonist, which is very exciting because shots are scary sometimes for kids. So there's a phase 3 trial in progress with adolescents with obesity and overweight with comorbidities, and there seemed to be about an 8% weight loss in those with adults, with type 2 diabetes. Other possible future directions, we can get even bigger and go triple agonist of GLP-1, GIP, and glucagon. Early phase trials in adults show superior weight loss up to 25%, which is wild. And then other combination therapies, including the combination of GLP-1s with leptin analogs or melanocortin receptor modulators. Should have just said MCR. That's what I should have said. So GLP-1 receptor agonists and digital therapeutics is also a future direction. There was actually a trial telehealth program that included video visits and check-ins with messaging with using GLP-1 medications, and this was done in Baton Rouge, Louisiana. And had one-on-one coaching, digital tracking, and medical treatment provided by board-certified physicians. This was paired with biweekly meetings and coaching over the first year, and members would regularly track their weight electronically and their habits. So that's an encouragement towards thinking about access to care and how frequently we can get to these visits. All right, here are my insane amount of resources. Questions before I go into questions?
Recently, if I'm not mistaken, the FDA said, they weren't authorizing or approving use of compounding pharmacies for semaglutide. And that obviously will affect the price, since a lot of people were saving money, I think, by getting their meds from a compounding pharmacy. Do you have any comments on that? I'm curious why the FDA did that, since unless it was just the influence of big pharma, because I don't know any other reason that they would do that.
Yeah, no, I think that's a really good point. I think with trusted compounding pharmacies, I think it is important and a possible medication that those with health disparities can access. But I think when I was looking into why the FDA does not support compounded medications, it primarily looks at, you don't know like what the percentage is of the medicine compared to the medicine that it's compounded with. And it could be like 5 to 20 times the amount of what's recommended, or it can be like nothing in the medicine if you don't know the compounding pharmacy that you're using, is kind of what their perspective was. So, and I think similarly with that perspective, it's kind of like thinking about supplements and things like that in terms of like they're not FDA approved, so they're not going through a, I'm losing my words.
Like a checks and balances.
Yes, with making sure that there is the significant amount of medication in the drug, or the amount that is recommended. So.
For some of these comorbidities, we would refer to endo, such as like diabetes. At what point, or like, would you, or do you know the criteria that you would refer to genetics? Is it just like really early onset?
So really early onset is a thought. I think also just evaluating the other impacts, the many other factors that can impact obesity. There are some monogenetic conditions that present very early. And oftentimes with obesity, it also comes with like developmental delays, intellectual disabilities, and things like that when there is a genetic cause. So that might be something to think about.
The pancreatitis, was it isolated pancreatitis, or was it cholelithiasis with pancreatitis?
So it was, so the liraglutide trial had one patient with pancreatitis, and then the semaglutide trial actually didn't have any patients with pancreatitis. And then the choledocholitis and cholecystitis in the liraglutide trial was similar in placebo, and I think there was actually like 1 or 2 in placebo versus intervention. And then with the semaglutide, there was more patients with the choledocholitis or cholecystitis.
Which makes sense because they lost more weight, right? And
Yes.
rapid weight loss
Rapid
as a
weight
risk
loss.
factor
Yep.
for choledocholitis. So,
Absolutely.
and I may have missed, did you say the risk with bariatric surgery of choledocholitis compared to the GLP-1s? Because to me, like, your rapid weight loss,
Yeah.
right? Like, are we overblowing this risk? And it's just when you have to lose a lot of weight fast, this is a risk.
Yeah, no, that's actually a very, very good question. I did not specifically look into that. I don't know if Dr. Powell happens to know. But I think that's a very good point because that is what is precipitating this side effect. So I'm not 100% sure on that.
Yeah, Matt, this is Dr. Bass. Nice presentation, and thank you for presenting the data. I really think it's important for surgeons and pediatricians to work together to try to combat the morbidity of obesity in children, because as you point out, it's just an entree to a lifelong risk of carrying the weight and exposure to all of those complications as an adult, the hypertension, the joint disease, the cardiovascular disease. So I really join in your enthusiasm for thinking about this, working with these kids. But the idea of, losing weight and that causing a risk for surgical interventions, I think that there is pretty good clinical experience and data to say it's the weight loss and the rapid weight loss that drives that. And as surgeons, we always talk about, risk benefits and doing that because we have more risk. And I would say that, the risk of choledocholitis versus the risk of sustained obesity, it's a no-brainer. The weight loss is the better choice.
Yeah.
Yeah. Great point, Dr. Bass. Thank you so much for attending and participating.
So I really enjoyed your presentation. I've certainly never prescribed any of these medicines yet, but I am really, really glad to have this information. I think it'll be really important going forward if we're going to talk about the questions that you had about the impact on growth and puberty. It needs to be in the context of what are the impacts of obesity on growth and puberty. I saw a 9-year-old yesterday who is 155 pounds. She is the same height as her mother, and she hasn't developed puberty yet, but she probably will very soon. In my previous clinic, I had an 8-year-old who started her period and ended up with a hemoglobin of 5. And, it's dangerous to have the secondary effects that estrogen in particular can have on these girls when they develop that adipose tissue so early. So I think it's going to have to be in some context and saying we have no idea what these medicines could do when we know what's already happening. And I think it is also just really interesting to put in the modern light of sort of health at every size. It's really interesting to me that all these studies continue to focus on weight loss, which is not always something we want in kids. For younger kids especially, I'm just looking for a decrease in the slope of the line. And for somebody to have lost 0 weight, but maybe not gained, is another criteria that I think would be really helpful if we're talking about under 14-year-olds who have already achieved an adult weight. I don't need them to lose weight. I don't want them to be less than 100 pounds. And so trying to come up with some different ways to discuss the success of these medicines and even micro-dosing or something to just barely. And I've definitely, the one thing I have done is I've put kids on tiny little doses of metformin, and I've looked them in the eye and I said, this is going to help you feel less like you're starving. That is my goal. It's also going to turn on your, insulin receptors a little better. But, my number one goal is I'm trying to help you do what your brain wants to do, but that your mouth and your salivary glands are fighting you on. So I think trying to figure out when we separate out kids and adults, which is so important, how we can really have different quantifying variables of what success looks like.
No, I think that's great.
I don't want scrawny skeletal anorexics.
Yeah.
Their own kettle of fish.
Yeah, and that speaks to, I think, like insurance looking at like weight loss is what they look at. Thankfully, the trials did look a little bit at like BMI, which looks at weight and height, as well as like BMI Z scores, which then looks at that change over time as well. But
you're not going to see fatty liver disease as the risk, then curing the fatty liver disease is not going to, So we need to convince them that those are the metrics that really do matter. Hemoglobin A1C even.
And along those same lines in our clinic, particularly the younger kids that we're not even talking about medications with, if they come in and when I ask their goals for being there, when the 8-year-old says weight loss, I quickly put no, we're talking about healthy eating. We're talking about maybe weight maintenance while you do some height growth, but we do not want to see weight loss necessarily in this clinic. And I think that's an important discussion too with the families. And part of our team does include a psychologist to help with some of those body image issues as well.
Yeah, on a similar note,
change the growth curve that has the weight line going straight up or the BMI line going straight up, which is more concerning. I see success when we can flatten the curve.
Yeah, that's a great point. And another thought is there is a way to measure the body fat percentage. And that might also be something to look into is, because, Dr. Powell also sees success in children that are losing body fat percentage and increasing their muscle mass. And I think that if these studies also showed, does this change body fat percentage? I think that could also be a very helpful marker.
I mean, there's just so many questions, which is it's really exciting. And I think one question, but it's just the number of kids I have that are 12 and 300 pounds is not small, and so this is just very, very pressing. I think one of the questions, and we've had discussions in the past of early weight trajectories, right? These kids who have rapid weight gain in infancy, toddlerhood, childhood, that sets them on a trajectory. Mm-hmm. Do we know that it's their neural pathways are setting down, their leptin, ghrelin pathways initially, and they're getting kind of warped by the way that they're approaching food? And so the question, one of the questions to me is when do we need to have them on, or do we need to kind of change the way they approach food to create lasting neural pathways towards food? And is that a chemical thing, in our brains, or is that a societal pressure thing or cultural pressure thing? And so that'd be interesting. The other question I have is, what do children's weights do when their parents are on this? Because, right, if you have a parent who's on it, she approaches, or dad approaches food differently, then how does that then, especially with education, how does that change their approach to their child's availability of food?
Yeah. Could you buy one, get one free?
Right. Or again, flatten the curve.
Yeah, that's a great, looking at family outcomes, and that I don't think anything has been done looking at that. And then in terms of what does it do to the neural pathways and things, I didn't look specifically into this, but in terms of learning with things previously, in terms of looking at things previously, increased fat increases or decreases your responsiveness to your hunger and satiety hormones, and so it very much influences that, and so that's part of the difficulty with kids when they're so early and gaining that weight. Losing that weight is really, really challenging because their neural pathways are adjusted based off of how much their body fat is.
Do you guys use the body roundness index in that clinic?
Ooh, good question. Dr. Powell, do you use the body roundness index or like a waist circumference, or what do you use?
We haven't used that at this point, but I've seen some recent literature suggesting that we probably should start looking at it.
Any other questions? Also, very special thank you to Dr. Powell, who is currently on vacation, but still kind enough to attend online. So thank you very much for your expertise. All right, some questions following our questions. All right, 13-year-old boy with obesity and prediabetes is being evaluated for possible pharmacotherapy. Which of the following best describes the primary mechanism by which GLP-1 receptor agonists promote weight loss? A, inhibition of intestinal fat absorption. B, increased urinary glucose excretion. C, stimulation of insulin release and delayed gastric emptying. D, suppression of hepatic gluconeogenesis. Or E, increased basal metabolic rate.
C.
C, yay. Just quick review. A is orlistat. B is SGLT2s. C is GLP-1s, and D is metformin, and E is phentermine. All right, number 2. A teenage boy and his parents are clearly distraught about his weight and request information about bariatric surgery. Which of the following best describes a potential candidate for bariatric surgery in adolescents? A 14-year-old boy at sexual maturity rating of 2 with idiopathic intracranial hypertension and a BMI of 135 percentile, who has failed to lose weight after 9 months of dietary weight management. B, a 13-year-old boy, SMR2, obstructive sleep apnea, BMI 120 percentile, who has failed to lose weight after 6 months of management. C, 14-year-old boy at SMR3 with type 2 diabetes, BMI 130th percentile, and failed to lose weight after 9 months of therapy. And then D, 15-year-old boy with SMR5 with BMI 130th percentile, who has failed to lose weight after 6 months of dietary weight management. And E, a 15-year-old boy at SMR5 with hypertension, diabetes, and a BMI 130th percentile, who has failed to lose weight after 6 months of dietary weight management. E, yes. Perfect. All righty. Well, thank you all.
Thank you, Dr. Swanson.